Good afternoon, Chairman and ladies and gentlemen. I'm Jiafeng Zhang from Taiwan. Now I'm going to talking about the role of virus in the Icbps patients. I have nothing to disclose. We know that Icbps, the diagnosis of IC should be made based on no evidence of urinary tract infection. But the question is, what is the urinary tract infection? Currently, the UTI was diagnosed based on the urinary culture of bacteria or the urinary analysis. But what does the virus infection present in the Icbps spread? Does the urinary virus have a role in Icbps pathogenesis? Only limited evidence investigate the association with urinary virus and IC. And a previous study used the PCR to detect the polyomavirus in the IC patients. And our recent study found using the in situ hybridization, we can find that the EB virus present in the IC blood specimen, especially in those with harness lesion. So we want to know if the virus present in the IC blood or urine. So we enrolled IC patients from our clinic and collected the midstream urine from analysis. Then we used the multiplex PCR to investigate the urinary virus in IC patients. This is our virus target, including the herpes virus, HSV1, 2, and the EB virus, the CMV, VZV, and the polyomavirus, BKV. And the previous study showed some respiratory tract virus, Boca virus, and the adenovirus presented in urine. So we also investigate that. We enrolled 55 patients, and including 9 harness lesions and 51 control subjects. And we only found the Boca virus and the adenovirus in the urine. The other targets, including HSV1, 2, EBV, this doesn't find in our PCR. In IC patients, the urinary PCR showed the Boca virus positive in 20%, adenovirus positive in 12%, and in the control subject, the Boca virus positive in 11%, while adenovirus just 23%. And there was no significant difference. When we counted the Boca virus over the adenovirus, there were also no difference between IC and control. The clinical parameter between IC patients with or without urinary virus also do not have significant between any symptom scores. So our study showed the virus could be detected in multiplex PCR, and the adenovirus and Boca virus could be detected in both IC and control patients. And our study also suggests the urinary adenovirus or Boca virus do not have an impact on symptoms. It seems adenovirus or Boca virus just randomly present in IC and control. So the role of the virus in non-urinary tract disease is still unclear. As we know, PCR result might be different when you using different primer, and the positive PCR might be just contamination. And we think if there were no evidence or histology evidence of blood inflammation, urinary virus just might be not meaningful. So we would try another EB virus primer to detect the EB virus in IC specimen, especially in those who with harness lesion, because our previous study showed the harness lesion has EB virus presentation. Thank you for attention.
Thank you. This paper is open for questions or comments. I was actually a little surprised at your last statement that you're still interested in looking at other primers and stuff. It seems like you have a pretty powerful study to show that there's no sign of anything going on. That's actually helpful. I know we want to get positive studies, but a good negative study is pretty helpful, and that seemed pretty negative.
But I have a technical question regarding the negative findings, and that what is the sensitivity of your assay in terms of PFU per mil or per microliter that you can detect with your PCR? And what would you expect as a viral titer to be in urine? Is it...
Yeah, that's a good question. And actually, we cooperate our another department in our college, so they do that. So actually, I don't know the cutoff value, but we think we should because our immunochemical study showed the EB virus presented in IC blood. So we will try another primer to detect the EB virus, because if we had evidence of the immunochemical staining, I guess we could find the EB virus in the urine PCR. Yep.
But that's an in situ hybridization, so you're really just staining for the viral genomes and B cells that are infected, right? Or what were those images that you showed there of the EBV positive lesions?
We do another immunocommunicable staining, and we found that the master EB virus positive should be in T cell. This was not. It is an unusual presentation because, as you know, it should be in B cells. Yeah.
So, I mean, was that staining for a viral envelope antigen, or what was that image that you showed of the lesion there? Was that an in situ hybridization for viral genomes, or was that a stain for actually structural proteins indicating viral production?
Actually, I'll do the in situ hybridization for EBER. For the pathology diagnosis, if the EBER present more than about 20% of the lymphocyte, that could be a consideration as acute. It should be acute infection, but acute is not active. It should be active infection, but not acute. That's what different means. Because maybe we can see some little EB virus in the in situ hybridization, but in our picture, they show the diffuse positive. Yeah.
Thank you.
Thank you.
Thank you very much.